recording my lecture. If you look at the slide here, it shows the structures of the urinary system, starting with the kidneys, most superiorly in this picture. Sitting on top of them is the adrenal glands, which we talked about in the endocrine system. If you notice, there is blood flow both to and from the kidneys, off the aorta to the renal artery, renal vein from the kidney back to the heart. We have ureters, two, one on each side, emptying urine to the bladder, which is a storage area for urine. And then most inferiorly, you have your urethra. In this picture, it's female, and so therefore it's obviously much shorter than you would see a urethra in a male. The next slide shows the kidney's position. This is a posterior view, and we're looking at the kidneys. The right side is a little bit lower than the left. They're retroperitoneal, meaning that they're outside of the peritoneum, one of the serous membranes. We see that there's some protection by those lower ribs of the kidney. I always remember as a child hearing a kidney punch. Don't hit somebody in the back like that because you can hurt their kidney. If you note its size, it's about 4 inches in length, each kidney. So not terribly big comparative to its responsibilities. This next picture here is showing the interior part of the kidney. This would be like a coronal view of the kidney, dividing it in front and back. And what we see, if we start on the outermost, you see the renal cortex. The renal cortex is where filtration occurs in the kidney. And the next area is the renal medulla. The renal medulla is the middle part of the kidney, and it encompasses the renal pyramids, which are these pyramid-shaped structures inside the kidney. We'll talk about its function shortly. The renal columns are cortical tissue that can be found in between the renal pyramids. So it's the same as this cortex in these columns here. And then the innermost, I guess, layer, you could say, of the kidney is the renal pelvis. So outermost, you have the cortex, then the medulla, then the pelvis. And all of that is surrounded by a fibrous capsule, a renal capsule that's like a tough fibrous outermost layer. So the renal pelvis is actually a collection funnel, you could say, for urine. After urine is formed, you have the minor calyx, which is at the end of each pyramid, and then a couple of them will combine to form a major calyx, and then the renal pelvis is a funnel shape, emptying urine into the ureter. Also, what you see here, this little indentation in the kidney, it's kidney bean shaped, haha, is the hilum, which is where the renal artery, renal vein, and the ureter are located. So the ureter exits, the renal vein exits, and the renal artery will enter at the hilum, the indentation in each kidney. The first question we see is where do blood vessels, nerves, ureter enter and leave the kidney? And that would be B, the hilum. The next concept we're going to cover is blood circulation to the kidney. If you start at the renal artery, the way I will describe it is that it just branches into each of the sections of the kidney, you see it's kind of surrounds each medulla and then gets smaller, smaller, smaller. And we'll see how microscopically capillaries around the nephron, which you can't see in this picture that's on here. And then you have the reverse of the venous system, bringing blood that's been filtered back into the regular circulatory system. So what I will describe for you, you do need to know the renal artery and the renal vein. But on the next slide, we'll see a couple of other blood vessels that you need to know. So if you look at this renal artery down here, hopefully you can see my little arrow. But you see at halfway through the picture, you see the red artery that's horizontal. And it says cortex and then medulla, and it's the vein, the blue vessel. Well, from that renal artery, you have the blood flowing to the structure that's called the glomerulus. And the vessel that brings blood to the glomerulus is called the afferent arteriole. The afferent arteriole brings blood through to the glomerulus, which is a bundle of capillaries, and this is where filtration occurs. You also can see that there's an efferent arteriole, and we saw that afferent and efferent concept when we did the nervous system, afferent going up and efferent coming down. Well, in this case, the efferent arteriole leaves the glomerulus. And if you follow it around, it becomes the peritubular capillaries. So in the nephron, there's two capillaries, one at the glomerulus and two at the peritubular capillaries. If you notice, the efferent is not blue, it's red. Both of these are arterioles. Afferent brings blood through, pushes most of it into the tubule, and then whatever doesn't fit through the filter that's in the glomerulus is actually kept in the efferent arteriole and has an opportunity maybe at another place on the nephron to enter into the tubule. But your bigger cells like protein and blood cells will not get through the glomerulus. The pores, the opening, is too small. So let's follow the circulation again. We have the artery, it would be the renal artery and then smaller, smaller, smaller till we get to the afferent arteriole to the glomerulus. The glomerulus is capillaries. To the efferent arteriole, to the peritubular capillaries, to a venule, back to the vein, back to the renal vein, and out of the kidney. So that's the circulation part. Now let's look at the tube part. Surrounding the glomerulus is what's called the glomerular capsule. Sometimes you'll see it listed as Bowman's capsule, capital B, person's name. The first part of the tubule is called the proximal, closer to, convoluted, directional, all over the place. And then you have the descending loop of Henle, the ascending loop of Henle, and then a collecting duct. So in this top part, in the cortex, is where the filtration is occurring. And if you recall from pharmacology, we talked about the processes of urine formation, including filtration, reabsorption, and secretion. And reabsorption is from the tube to the capillaries to the bloodstream, and secretion is from the bloodstream back into the tubule. Ultimately, the outcome is urine being made. So all along the tube, you can have fluids and electrolytes going back and forth. And ultimately, the urine is going to depend upon what's been absorbed, what's been reabsorbed, and what's been secreted. So you should know the blood flow as well as the flow through the tube. The next slide is the renal corpuscle. We look at the corpuscle including the renal capsule or Bowman's capsule and the renal tubule. So I'm sorry about that. The Bowman's capsule and the glomerulus is called the renal corpuscle. You have the proximal convoluted tubule that comes right off of the Bowman's capsule. So this is a really good picture where you see the afferent arteriole bringing blood into this bundle of capillaries, and you see the arrows going into the Bowman's capsule where pretty much everything except for big cells enter into this capsule and immediately go into the tube. Whatever doesn't pass through goes out the efferent arteriole. So this next slide is looking at the renal tubule. We see the afferent arteriole, we see the glomerulus and the capsule making up the corpuscle, and then you see the tubule. And the flow through the tubule of filtrate is going to be proximal convoluted tubule, descending loop of Henle, ascending loop of Henle, distal convoluted tubule, and collecting ducts in that order. This is stretched out and pretty linear compared to the way it normally is. The previous picture showed how convoluted, how bunched up the tubule really is. But this is the flow of what is filtrate. Filtrate is whatever passed through this Bowman's passed into this Bowman's capsule. So one of the structural benefits of the proximal convoluted tubule, which is this area right here, is that it has an increased number of microvilli. If you remember earlier on when we talked about cells and tissues, the microvilli purpose is to increase surface area. And you'll see microvilli in structures like the small intestine, in this case in the proximal convoluted tubule, because of reabsorption. So you have lots of microvilli in that area, so that's where a lot of stuff gets reabsorbed. Okay. So this has the peritubular capillaries removed, and all we see is the tubule. But as the filtrate is going through this tube and going back and forth between the tube and the bloodstream and the tube, what happens is at the end, when we get over towards the collecting ducts, what we have is urine formation. And on the other end of the collecting ducts would be your calyces and your minor calyx, your major calyx, as well as draining then into the pelvis. So what are the filtration units of the kidney? Where does filtration occur? And that would be at the nephron. A nephron is where filtration occurs. So let's talk about the three processes again of urine formation, and that includes glomerular filtration, tubular reabsorption, and tubular secretion. So first things first is glomerular filtration. Hope I did this right. I'm going to start again on glomerular filtration. If you look at the picture on page 361, you see the glomerulus at the bottom, which is the bundle of capillaries. You see the Bowman's capsule that surrounds the capillaries, the glomerulus. You see the afferent arteriole bringing blood to the glomerulus, the efferent bringing blood from the glomerulus. And then the enlarged picture shows the pores that are found in the capillaries. So the pressure from the afferent arteriole, if you notice, it's a little bit bigger than efferent. The pressure that's there allows for this anything that can fit through the pores of the capillary to get through and enter into the Bowman's capsule. So if you could go to number 3 on 361, talks about the glomerular filtration rate. So 180 liters each day is filtered by both kidneys, 60 times more than the body's total volume. And the body, the kidneys, will reabsorb 99% of that filtrate, only allowing us to excrete 1 to 2 liters as urine. Quite efficient at concentrating the urine, and all through the processes that we mentioned: filtration, reabsorption, and secretion. So Fast Fact on the same page talks about most of the calcium, iron, and thyroid hormone that's in the blood is bound to plasma proteins, which prevents these solutes from being filtered out of the blood in the glomerulus. So in addition to bigger blood cells and plasma protein, it's things that are bound to that will also not get filtered in the kidney. So this, where the Bowman's capsule, the glomerular capsule, and the capillaries meet is kind of, you can think about it like the alveoli and the pulmonary membrane and pulmonary capillaries, that it's one cell thick. So if you look at the body at work at the bottom of 361, talking about the damage to that glomerular capillaries, if somebody has say, urinary tract infection or other inflammatory kidney things, you'll see that the urine will contain protein or blood cells. So we already mentioned that normally that wouldn't get through. So if you have blood or protein in your urine, you know we've got a problem. So on the bottom of that page, the presence of protein in the urine is normally abnormal. It's called proteinuria. It can occur after physical exercise, but it also would represent that there's something wrong with that filter at the glomerular capillaries. So next slide. So the regulation of glomerular filtration rate is something that we keep in mind as nurses. It should be constant. So you might have shifts in blood pressure, but the glomerular filtration rate should be constant. So if the flow is too high, the body's going to lose too much. If the flow is too low, the tubules may then reabsorb toxins, and that wouldn't be good. So before I start talking about RAAS, two things. One, we mentioned that diabetes and its effect on the kidney a couple of times this semester, but also hypertension. And if you look at the life lesson, hypertension and kidney damage on 361, is that kidney damage and kidney failure is a common cause of that is uncontrolled hypertension. So because uncontrolled hypertension will push the normally high glomerular pressure even higher. So as a result, the capillaries, the glomerular capillaries, can burst and then scar. So hypertension can also cause atherosclerosis and in blood vessels throughout the body, including the kidneys, and can damage the kidneys by reducing blood flow to the kidneys, which is interesting. So kidney disease can cause hypertension. Hypertension can cause kidney disease. So now we can look at RAAS, and that's a Renin-Angiotensin-Aldosterone System. And if you look on page 362, it talks about it beautifully. And what happens when there's a reduction in blood pressure, there are cells that are at the afferent arteriole that will release renin. And renin, we know, converts angiotensinogen into angiotensin 1. And angiotensin 1 will be converted to angiotensin 2 by the enzyme angiotensin converting enzyme, which comes from the lungs. So when angiotensin 2, what angiotensin 2 does is a couple things: vasoconstriction, but also causes the release of aldosterone, a mineralocorticoid that comes from the adrenal cortex. And aldosterone, we know, causes the kidney to hold on to sodium, so therefore hold on to water, therefore blood pressure increases. So we talked about meds to lower blood pressure that acts on this system. There's one that acts on renin. We have angiotensin converting enzyme inhibitors that will block the conversion of angiotensin 1 into angiotensin 2. And we also have a angiotensin 2 receptor blocker that's going to lower blood pressure because it's going to stop aldosterone from being released, stop the vasoconstriction, etc. So hopefully that is just another way to look at it. Renal reabsorption and secretion is this next slide. And you see that this nephron has been totally stretched out. And starting from the far left, you have the glomerulus, and immediately things get pushed through as filtrate into the tubule. But almost right away in that proximal convoluted tubule, you have reabsorption back into the bloodstream of most of the things that went through: sodium chloride, water, glucose, potassium, etc. But all along the peritubular capillaries, as it continues around the nephron, you'll see that they'll be shifting back and forth of things, depending. Could be under the influence of hormones, could be under the influence of concentration. So you'll see that most of the water is reabsorbed from this descending loop of Henle. And we talked about the action of diuretics, that there's a higher concentration of sodium in the loop versus in the distal convoluted tubule. So when we talk about how sodium moves, we know that sodium moves by active transport, and you see at this loop of Henle, you have that sodium arrow, but you don't see the water arrow. And part of the reason why is because of the permeability of that, the thicker tissue of that ascending loop. Doesn't allow water to get through, but does allow sodium. And when you get to the collecting ducts, you have some reabsorption of water, which is going to concentrate the urine in there. Going from here, you have the minor and major calyx pelvis out of the kidney through the ureter down to the bladder, and where it's stored until it's able to be excreted, eliminated. So most sodium is reabsorbed from the glomerular filtrate right off the bat, right off the corpuscle at the proximal convoluted tubule. Answer is A. Oh my, I was right. Okay, so let's look at, excuse me for that yawn, but let's look at the next slide talking about hormones and how they work on the urinary system. Some of this may sound a little familiar. You have aldosterone, which will reabsorb the sodium, therefore water. ANP or ANH, sometimes you'll see atrial natriuretic peptide, will excrete sodium and water when there's an increase in volume and stretch of the atria. ADH reabsorbs water. Notice there's no sodium there. Antidiuretic hormone comes from the hypothalamus to the posterior pituitary. And as a result of reabsorbing water, you'll have increase in blood pressure. And parathyroid hormone is involved in reabsorption of calcium. Calcium and phosphorus are on a seesaw. They're opposite each other. So when calcium's high, phosphate's low, and vice versa. So we talked about parathyroid hormone in the endocrine system, that it will elevate blood calcium levels. So you see the reabsorption of calcium from the tube into the bloodstream would contribute to that. Interesting description of how diuretics work, which you should know from pharm. But a diuretic is used to increase urine volume, often to lower blood pressure. So it's used for heart failure and hypertension. So diuretics, we know, block sodium, therefore water. Interesting that caffeine will dilate the afferent arteriole, causing increased glomerular filtration rate. That's why people that drink a lot of coffee might have increased diuresis. So next slide, or this slide, is talking about the composition of urine. What does urine contain? So it's mostly water, as you can see, and then there's dissolved substances in there. And we can assess urine contents and concentration and pH and specific gravity to give us an idea of what's going on with the kidney and the person in general. So you'll see on 365, we will use a dipstick sometimes where we'll assess the pH. You can see maybe if there's any blood or white blood cells in there, but you can assess the color. Usually urine should be in the yellow family, ranging from pale to amber color, which has a little bit more brownish red in it. Generally, if somebody has darker urine, it could be representing that they are dehydrated, haven't drank enough. And you'll also look at the clarity of urine. It should be see-through, that you can see through. You shouldn't see sediment, or it shouldn't be cloudy. You're thinking that it's possibly an infection if you see cloudy urine. Another thing that we look at with urine sample would be odor. The odorous urine could be telling us that there's a urinary tract infection. You have to be careful because the longer urine sits out, you can have oxygenation. The bacteria breaking down the urine, and it could be a foul smell. Also, if it is sweet smelling, could be telling you diabetes. And like I said, a foul odor could be a urinary tract infection. The specific gravity is a test that tells us about concentration, essentially. So the higher the specific gravity, the more concentrated the urine is, therefore potentially that they're dehydrated, and vice versa. The lower the number, the less concentration. So normal range for specific gravity is 1.001 to 1.035. And normal pH is around 6. And we know a condition of alkalosis or acidosis. If it's a lower pH, it's acid, and higher pH would be acidic. So if you look at page 365 in the middle box, it's just talking about what we look at with looking at urine. But on the bottom right, it talks about some terms. Normally we produce about 1 to 2 liters per day. Urine output less than 400 is called oliguria. It's insufficient for clearing waste products from the body. Some diseases, such as diabetes mellitus, cause urine output to increase significantly. In this instance, it's that glucose that opposes the reabsorption of water, causing more water to pass through the kidneys and out of the body as urine. The other is diabetes insipidus. So diabetes insipidus, somebody has low ADH, and therefore they're not reabsorbing the water, and they have lots and lots of dilute urine. Clear, looks like water. So other terms for urine would be anuria, which would be without. And we're concerned that somebody should be producing at least 30 mLs an hour. So we're keeping an eye on output and reporting it. Keeping an eye, should have been covered with you for 105. So it should make sense what we're looking for as far as our assessment of urine and the composition. The composition ultimately reflects what's happened in that nephron, what's been reabsorbed, what's been secreted, what's been filtered, and the health of all of those. So if there's a problem with the filter itself at the glomerulus, you might see blood in the urine. Well, normally there's not blood in the urine. Just like we've talked about, like hair and skin and eyes can tell us a lot about a person's health. So can urine. Next slide's talking about the storage and elimination of urine. After urine is formed and goes to the minor calyx, the major calyx to the pelvis, out the ureters, it gets stored in the bladder. And as a young person, you don't have control over your elimination, but as you pass through toddlerhood, you gain control of urination that continues throughout life. So the next slide shows the bladder, and let's look at these two sphincters. You have an internal urethral sphincter and an external urethral sphincter. And as an adult, you have control of the external urinary sphincter. You can choose when you urinate or where you urinate. The other thing that's interesting in this picture is that the ureter actually enters into the bladder low. It's kind of misleading. It looks like it's entering into the bladder high up, but it's actually entering low. So this is where the ureters are entering. And you see the structure, the trigony, the bladder, it looks like almost like a triangle. It's in that area where you have, it's an area where there's often infections in this area. So the trigony is really made up of the three openings. It's this triangle looking thing, but you have the two openings to the ureters, but also you have the opening to the urethra, which is how the urine exits the body. So you have this is the peritoneum, the serous membrane, and you have the detrusor muscle. Just a couple more things as you think back to tissues. We talked about, I think that was chapter 4, we talked about a unique type of epithelium in the bladder called transitional, and it allows for the bladder to stretch so it allows it to hold urine. So rugae is folds that can kind of, not lack of a better word, I'm going to say expand as volume increases. And that detrusor muscle is the muscle of the bladder. So you see male and female bladders and the length of the urethra differences. Here's the male urethra is quite long compared to the female, which is a rationale for why females get more urinary tract infections. The male urethra also serves as the exit for urine as well as semen, and it's related to the other structures that are located around the urethra. If you see where my arrow is right here, this is the prostate gland, and those of you that work with elderly males may be familiar with people that have what's called benign prostatic hypertrophy, where this enlarges and kind of compresses on that urethra, making it difficult to initiate their stream, as well as another classic thing is dribbling urine, and it can be quite disruptive to sleep in that they awaken, need to stand up to urinate, And by the time you get them back into bed, they're, feel like they have to go again. So incomplete emptying is another thing. So the close proximity of the urethra, the shorter distance from the urethra up to the bladder, the proximity to both the vagina and the rectum contribute to the higher incidence of urinary tract infections in females. Most common cause of urinary tract infections in females is E. coli, which can be found in the GI tract normally. It's normal flora. Not normal flora in the urinary tract. Cool picture at the bottom of page 367 looking at kidney stones. And kidney stones can be made up of different things, calcium, phosphate, uric acid, and protein, that will harden, crystallize in the kidney and in different spots. As you see, another name for renal kidney stones is calculi. And they could get lodged and contribute to the inability of urine to flow. In some cases, it's bad and even backs up, and you have a condition called hydronephrosis. If urine can't come out, it backs up, and it could cause pretty significant damage. So what they'll do is they'll use shock waves as one way to break up the stone into pieces where it can get past. Another is they might have to actually go in and surgically remove it. They might go up through the bladder, up into the ureters, up to the kidney to get the stone. It depends. And there's also some medications that are maybe used to like break it down. It depends on what it's made of. If somebody's had one, they're more prone to having another one. It can be significant pain that may bring somebody to the hospital. Some care for somebody with kidney stones would be, until they pass the stone, they should be straining their urine, and they'll give them like a little plastic colander so that they can save the stone and have it analyzed to see what it's made of. Because it could be related to hydration status, immobility, certain medications. So it's important to understand, or it could be infectious, what the cause is so it can be treated. So the process of elimination is not as simple as you just feel you have to go. So as the bladder gets filled with urine, that stretch of the bladder, the impulses get sent to the spinal cord. Spinal cord sends motor impulses back to the bladder, and motor impulses are going to cause contraction to cause urination. We talked about the pons in urination, and that in the case of urination, that the pons can override impulses to urinate. Is this a good time to stop? Do I have the proper bathroom? So that override of the impulse is completed by the pons. So if its timing is right and place is right, then we're going to have contraction of the relaxation of the sphincters, contraction of the bladder, so that we can urinate. So the triangle-shaped smooth area on the floor of the bladder is called the trigonine. Good. Cortex is the outermost part of the kidney itself. The papilla is the end of the renal pyramids right before the minor calyx. And the rugae are the folds in the bladder. We'll see in digestive, it's folds in the stomach. So that is it for this lecture. Be sure you take a look at the life lessons and fast facts. There's pretty cool stuff in there. The last life lesson is renal insufficiency and dialysis on the bottom of 368. And it talks about why dialysis is done, but also the different types of dialysis, hemodialysis and peritoneal dialysis. So in hemodialysis, blood is pumped from the person's body into a machine, a dialysis machine, and the machine and the membranes of the machine and diacylate will do the work of the kidney and eliminate waste products. So completing labs is important. Completing weights is important. You want to make sure with hemodialysis that enough weight is coming off, enough fluid is going down. If somebody's kidneys aren't working, they could be retaining a lot of fluid. Peritoneal dialysis is they're using the peritoneum as the machine. And so the fluid is put in through a catheter into the abdomen, and the fluid is poured into the abdomen. It can be kept there. Sometimes it's done over a period of time, and the waste products, because of principles we've talked about already, will diffuse out and into the dialysate. And so then after that, the fluid is drained. So people that are doing peritoneal dialysis can do it at home in their own house. Pretty cool. All right, and that's it for that. And I'll see you in the digestive chapter.